Hello, I'm Jody Hoyo, CEO of the Prevent Cancer Foundation. So thrilled to be here with all of you today and was very excited to see that there were some props going in for our background music. I think it's the first Prevent Cancer dialogue where we've ever had excitement about the background music, but the music from Encanto seems to do that for people. Today, we are discussing guidelines, methods, and advancements for prostate cancer screening. And we are very excited to present this dialogue in partnership with Zero Prostate Cancer. Prostate cancer screening is not always straightforward, and it's definitely not a one-size-fits-all. Today, we'll dive into some of the nuances, including the benefits and harms of screening, racial disparities, and challenges with screening guidelines. We want to find and support the best ways forward so that more people can achieve better outcomes. This is actually our third and final dialogue webinar this year, and we are very grateful to those of you who have signed on each time. And to those of you joining for the first time today, welcome and thank you for being here. We at the Prevent Cancer Foundation are working towards a world where cancer is preventable, detectable, and beatable for all. The only way we can do that is together, and we're honored to be on a team with each of you. We're really looking forward to an exciting exchange of ideas, and we want to hear from you. You can enter in any of your comments or greetings in the chat box today, but be sure to enter your questions into the Q&A box. Of course, today is just a start. Please keep the conversation going. Talk with each other and bring ideas back into your communities and beyond. You can join in all day today and beyond into our social media channels as well. So you'd want to use the hashtag #PreventCancerDialogue and tag @PreventCancer. For your future planning, the dialogue will be back virtually in 2025. So keep an eye on your emails or visit preventcancerdialogue.org for the most up-to-date information. And I know this gets said all the time at meetings, but truly, the event would not be possible without our sponsors. I'd especially like to thank our gold sponsor, Exact Sciences, and our silver sponsor, Asai, for their generous support. Thank you for believing in our mission and helping to move this important work forward. And thank you to the hardworking Prevent Cancer staff who bring this dialogue to life. Our sincere gratitude to Erica Childs-Warner, Heather Thompson-Mackey, Adrian Harkness, Jennifer Nyangoda, Kira Meister, Sophia Matthews, and Tara Williams. It is now my pleasure to turn things over to our moderator, Brian Bragg, Chief Mission Officer at Zero Prostate Cancer. Mr. Bragg brings with him 20 years of experience in public health and health promotion, with an expertise in community and population health and health systems integration. We're honored to have him leading our discussion today. Please welcome Brian Bragg.
Thank you, Jody, for the warm welcome. And good afternoon, everyone, and welcome to the Prevention Cancer Foundation's dialogue. Today, as she mentioned, we are talking about updates in early detection and prostate cancer screenings, and we have two fantastic presenters to speak on this very important topic. First up, we'll have Dr. Kelvin Moses. Dr. Moses is the Joseph A. Smith Directorship in Urologic Oncology Chair and Associate Professor of Urology at Vanderbilt University Medical Center. He serves as the Program Director for the Urologic Oncology Fellowship and is the co-director of the Comprehensive Prostate Cancer Clinic. Dr. Moses is a Phi Beta Kappa graduate of Morehouse College and received his MD and PhD at Baylor College of Medicine. He completed his urology training at Emory University and a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center. His research centers on the impact of health literacy on cancer treatment and outcomes, optimal treatment for patients with advanced renal, testes, and penile cancer, and addressing the rising cost of care for cancer. Without further ado, I turn it over to Dr. Moses.
Hello, and thank you for the kind introduction. I'm honored to be on the panel with Mr. Bragg and Dr. Carlsson, who will be coming up. And I will start with my presentation. So for my portion of this, we'll be discussing basically an overview of prostate cancer screening for today. And really where are we now, and also how did we get here? And why is PSA or prostate cancer screening such a controversy? These are my disclosures. So I'll start a bit with prostate cancer epidemiology. I know this is a knowledgeable audience, but just a bit of an overview. And then I'll review how the United States Preventive Services Task Force came up with their original screening guidelines for prostate cancer and then with their current guidelines. And then we'll go over some contemporaneous data on prostate cancer screening, leading into Dr. Carlson's talk on where we should go from here. So I'll talk about PSA screening first, and for those who may be on the fence about it or in the primary care world, don't shoot the messenger. So prostate cancer is the most commonly diagnosed solid organ cancer in men, with over 299,000 will be diagnosed this year, and is the second most common cause of cancer death, with over 35,000 estimated for 2024. You can see in the brown line, sort of in the middle there, prostate cancer death rates slowly rose over several decades. And then you see a drop off starting in the early to mid 90s. And that's basically about 5 to 10 years after PSA started being used as a screening tool. And then you see it starts to flatten out there towards the end. And we'll talk about why that curve is shaped like it is. Overall, about 1 in 8 men will be diagnosed with prostate cancer at some point in their lifetime. So this is really a prevalent and important disease. So let's talk about what is a good screening test. Well, number one, the benefits are, or what is beneficial, it should be a serious enough disease where screening is economically and socially feasible. It should allow for treatment before symptoms occur, which would be more effective than treatment at the time of symptoms. And the prevalence of the disease in the detectable preclinical phase is relatively high. And prostate cancer likely falls into all of these categories. The test should be inexpensive, easy to administer, minimal discomfort, reliable, and valid. So that's where some of the issues come with PSA testing. Number one, it just gives you a number, and really there's no such thing as a positive test, and really worse, there's no negative test. There's no number below which there's nobody that has prostate cancer. Additionally, not all prostate cancers that are diagnosed will become symptomatic or fatal within one's lifetime. And then really the last and biggest problem is that the use of PSA became widespread before any type of randomized trial could be performed to truly determine efficacy. And to be perfectly honest, PSA was actually never meant to be a screening test. So when you talk about prostate cancer screening and screening for any cancers in general, you talk about some of the harms that can occur with screening and treatment. Primarily, there can be overdiagnosis. So that means we're diagnosing a lot of cancers that will never become deadly. And again, we have no positive PSA or way of predicting if someone is diagnosed with prostate cancer, if it will become fatal disease. But when the USPSTF was reviewing their literature on biomarker studies, on PSA testing, they did not look at literature on biomarker studies for prognostication, which we have a robust literature about that now, nor did they consider the burgeoning utilization of active surveillance or close monitoring for men with low-risk, non-fatal disease. So really, though, when you're talking about PSA screening harms, this is really the only true harm that as a result of PSA testing is overdiagnosis. Now, subsequently, you can have overtreatment, and that really falls on the heads of people like me, urologists and radiation oncologists. And that means that we were treating men for cancer that would otherwise not become fatal, and thus placing them at risk for complications such as erectile dysfunction and urinary incontinence. So the two trials that the USPSTF used for coming up with their grading were the European Randomized Study of Screening for Prostate Cancer, or ERSPC, and the United States Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial, known as PLCO. So the ERSPC was held in multiple European countries, over 182,000 men who were screened anywhere from every 2 to 4 years, depending on where the screening site versus no screening at all. And their outcome was prostate cancer specific death. And as you can see on the curve here to the right, the blue line are those who received screening, and the red line are those who did not in the control group. Now, when this paper came out in 2009, their median follow-up was 9 years. That's a bit problematic because the natural history of prostate cancer can be anywhere from 15 to 20 years. And so anything that reports out that early may be a little bit too short, as those men would survive anyway. But what they did find was a significant reduction in the risk of death of 20%. However, it was a large number that was needed to screen to save one life. So over 1,400 men needed to get testing to save one life. And you had to diagnose 48 cancers in order to save one person. And so their conclusion was that PSA screening did reduce the risk of death by 20%, but was associated with a high risk of overdiagnosis. The PLCO trial performed in the United States, over 76,000 men who were randomized to annual screening and rectal exam versus what was called usual care. And so it's actually not no screening. And the outcomes were prostate cancer incidence, deaths, and then prostate cancer specific deaths. And as you can see in these curves here to the right, the blue and red line are basically overlapping each other as far as risk of death. This paper, both of these papers came out in the same issue of the New England Journal of Medicine. This one was reported at 7 years, which was even shorter. And not surprisingly, they found no difference in the risk of death between the two groups. And so their conclusion, after 7 to 10 years of follow-up, the rate of death was very low and did not differ significantly. Some problems with PLCO, though. Up to 50% of men in the control group got at least one PSA during the study, and 44% had a PSA prior to entering the study. So what we call contamination, there's some papers that show up to 90% contamination of the control group. So there's really not an accurate comparison. However, based on these studies in May of 2012, the USPSTF said there's moderate certainty that the benefits of PSA screening do not outweigh the harms, and they gave it a grade D, meaning recommending against the service. And predictably, among the prostate cancer practitioners and even patients and advocates, there was a bit of an outcry. Some literature that came out subsequently showed the effect of the change in PSA screening grading. And in this study that came out of Vanderbilt, my institution, there was a decrease in the number of men who were diagnosed with low-grade cancer, which is actually a good thing because, again, we believe that the vast majority of these men either don't need treatment or can be monitored very closely. What was also found was that there was actually a significant decline in the number of intermediate and high-grade cancers, which could become fatal at some point. And that decline means that we're missing some significant cancers in this era immediately after the screening recommendation. And as is often seen when there's a decline in what is felt to be a beneficial intervention, the decline was worse in Black men. And so in this study that came out in 2020, the decline in PSA screening was significantly higher in Black men, where 11% decline versus 9.3 in white men. The incidence ratio increased in Black men, and the incidence of metastatic prostate cancer increased in both groups. So these were some worrying trends that were noticed in the first 10 years or so after the screening guidelines changed. In this study of 2015, they showed that the relative risk for high-risk cancer increased 9-fold, or 25%, after PSA screening. And what we said, again, it's early. This was reported approximately 4 years after, but it's a problematic trend because, again, these men are now at higher risk disease, meaning they need more radical treatment, more likely risk of side effects and complications, and higher risk of death. So I mentioned that the ERSPC was reported at 9 years. And at 13 years, you can see that these curves start to separate. This is where the paper came out, and this is at 13 years. And so the reduction in the risk of death actually became even more significant over time. And now at 13 years, the number needed to screen dropped by almost half. The number needed to diagnose dropped significantly. And the ratio for screened men was at 73%. And at 16 years, these numbers continue to improve. So now it's down to 570 need to be screened, and with only 18 excess diagnoses. And really the most important difference was that there was a very significant a very significant drop in the number of men who were diagnosed with metastatic disease or diagnosed at a PSA of greater than 100. So over 3 times less likely to get metastatic disease. And so it confirms that the reduction of metastatic disease at diagnosis in the screening arm, it also precedes the mortality reduction by 3 years. And so there has been, again, subsequent studies looking at or accounting for some of the problems that were both in ERSPC and PLCO. And in this study, where they reconciled the effect of screening on prostate cancer death, they did show that prostate cancer screening reduces death somewhere around 30% in both the ERSPC and PLCO group. And that's really a significant number. There's actually really not a lot of screening tools that can show that amount of reduction of risk. So let's go to our question here, and the poll. You have the ability to answer the poll, but what is shared decision making? And I just want to get the sense of what the audience thinks it is. Is it a conversation between the clinician and patient regarding a medical decision where preferences play little or no role? B, the patient leaves a decision regarding screening to the clinician. C, the clinician offers options and describes the risks and benefits, and the patient expresses their preference and values for a preference-sensitive medical decision, such as screening. Or D, the patient shares their medical decision-making with relatives or friends. So if people can answer the question here, and I'll have the moderators let me know when I can proceed. Okay. So let's talk about the current screening guidelines, and this will lead into some of the conversation that we'll have with Dr. Carlsson. The American Urological Association, or the AUA, emphasizes shared decision-making, and I'll explain it as shared decision-making, again, is the physician offering or discussing what the screening test is, what it's looking for, what the risks and benefits are, and then discuss with the patient what their values are, what they prefer, and how that fits with their screening decision. So the AUA recommends shared decision-making between ages 55 and 69 with normal life expectancy. And for the most part, that's with at least 10 years lifespan. They do recommend selected screening at men at higher risk at 40 to 55. And that's really a positive first-degree family history and in Black men. Some men 70 and older and in excellent health may also benefit from screening. The National Comprehensive Cancer Network, the NCCN, of which both I and Dr. Carlsson are members, again, shared decision-making, age 45 to 75. The frequency of testing can be lowered based on a baseline measurement, which we recommend earlier. And then, again, you can screen and select very healthy men older than 75. The USPSTF has upgraded screening to a grade C based on some politicking, but also some discussion and new literature. They restricted to ages of 55 to 69. Men in reasonable health should discuss risks and benefits. The American Cancer Society also recommends informed decision-making starting at age 50 with good life expectancy, starting at an earlier age, 45, in Black men and those with one first-degree relative diagnosed before the age of 65. And then starting at age 40 in men at higher risk, so greater than one first-degree relative diagnosed before age of 65. And then lastly, the Prostate Cancer Foundation came up with screening guidelines specifically for Black men. And Dr. Carlsson was actually on this panel. And what they came up with based on the literature knowing that Black men are at twice the risk of death from prostate cancer and diagnosis with higher grade disease. And so they recommend Black men should, again, obtain information about PSA screening, so the shared decision making. Consider a baseline PSA somewhere between age 40 and 45, and then strongly consider annual screening. So some issues with cancer screening. What is shared decision making? I, as a urologist and surgeons, we always give patients all of the options for treatment or management or screening. Well, you can always lean somebody in the way that you think is the best. And our primary care colleagues are the ones who are usually having this discussion. And so is there a protocol for shared decision-making? Are there bullet points? What are the risks and benefits that each primary care physician is discussing? And even in a group of urologists, you can get an hour-long discussion about how screening should be done. And so we understand that primary care physicians, they have multiple guidelines that are published, and there's no consensus. And really, they follow USPSTF. And then the primary care physician has other things they have to worry about. They have to do cholesterol screening, diabetes screening, checking if there are firearms in the house, mental health screening. And so in a 15, 30-minute or even an hour visit, how much time could be dedicated towards this? And then also there are plenty of biomarkers and advanced imaging that can be used as part of screening that can reduce the burden of the biopsy or treatment that need to be integrated. And that really falls upon the thought leaders to update our guidelines to integrate this. So what's the way forward? I believe we do need harmonization of the guidelines. All of the stakeholders have their own opinions and financial backing and all the things that go with it. But I really think to decrease some of the confusion that is seen on the patient level and on the treatment level, we need harmonization. At our institution and several others, we have the primary care do age-appropriate screening and then refer to urology for an advanced level discussion. We absolutely must eliminate the screening disparity and treatment disparity for prostate cancer in the US. Even if we only reduce the disparity between Black men and white men, you would see a significant reduction in the mortality and morbidity burden of prostate cancer in this country. And part of that would be for advocation. We as physicians, nurse practitioners, APPs, and advocacy groups need to go to our state and federal governments and advocate for no-cost screening to allow for men to at least get that first step done. So I thank you for your time, and I will hand it back over to our moderator and Dr. Carlsson.
Thank you, Dr. Moses. I appreciated the context for how we got to where we are currently in the prostate cancer screening conversation, and I really do respect the items that you have listed here for the way and the pathway forward. So I look forward to our panel discussion where we can engage with participants on those helpful points. I do want to reiterate, if you do have questions, please get those into the Q&A section on our Zoom, and we'll be able to use those as we get to later on in this dialogue, where we can have those questions asked and answered and really have a robust discussion. So next up is Dr. Carlsson. Dr. Carlsson is the Director of Clinical Research at Memorial Sloan Kettering's Josie Robertson Surgery Center and Assistant Attending Epidemiologist at Kettering's Departments of Surgery, Urology Service, and Epidemiology and Biostatistics. Her line of research focuses on screening and early detection of prostate cancer, including multiplex testing and risk stratified strategies that incorporate clinical information, biomarkers, and MRI, as recently funded by the NCI 01 award. She also holds an appointment as Associate Professor of Experimental Urology at Gothenburg University in Sweden, where she's an investigator of 2 large randomized controlled trials of prostate cancer screening, which Gothenburg 1 and 2, as recently published in the New England Journal of Medicine. She is an adjunct senior lecturer at Lund University in Sweden, and she serves on the NCCN and AUA guidelines for early detection of prostate cancer and was the methodologist for the Prostate Cancer Foundation's guideline on prostate cancer screening for Black men in the US. She recently received the Platinum Award from the European Association of Urology, and her Prevent Cancer Foundation funded research has focused on developing a decision support tool for prostate cancer screening using innovative technology. Thank you for being here, and I turn it over to you, Dr. Carlsson.
Thank you, Mr. Bragg. Okay, that was a wonderful overview by Dr. Moses. It fascinates me. I've been doing this for 20 years, looking at this blood test that you see here on the screen, and it is still so controversial. But the good thing, in my view, is that we have come far. We have now better ways to screen and smarter ways to screen, and I'll show you a bit about that. Because back in the days, we used to only have palpation of the prostate with the finger or this blood test, PSA, but there's so much more we have in our toolbox today, so I think it's really exciting. But still, this test that you see on the screen is a really powerful marker of prostate cancer. It has some false positives because it can be elevated for other reasons, for example, an enlargement of the prostate, but it is a very, very good marker for prostate cancer. So, for example, we have done some studies showing that if a man is 60 years old and the PSA test is less than 1, the reason or something bad happening to him in the future is very, very low. So the risk of developing metastatic prostate cancer that has spreads to parts of the body or dying from prostate cancer is very, very low. It's only 0.2%. So if you're a man who's 60 and your PSA is less than 1, it's a very, very low risk. And the other good part is that if you go get a screening test as a man, most men will have a normal PSA, meaning that most men will be reassured. So it's a good screening test in that way too. And if it's an elevated value, we have so much more that we can do today. So in my view, and having studied this for 20 years, it's still the best marker we have to screen for prostate cancer. And these are my funding and disclosures. So going into what we call risk stratified screening, which is the topic of my talk, I wanted to ask you which of the following you think is true about risk stratified screening. Does it reduce a man's risk of dying from prostate cancer? Does it reduce a man's risk of being diagnosed with indolent prostate cancer or reduce overdiagnosis? Does it reduce a man's risk for unnecessary prostate biopsy, or is it all of the above? The correct answer is all of the above. And if you answered something else, then that means you're all right. So smart screening can actually then keep the benefits and reduce the harm. So that's really the purpose of all of this. And you heard Dr. Moser present studies from Europe, and I have been an investigator of those, the Göteborg trial in Sweden, and then the European trial, and Sweden was part of that trial as well. And you can see, and we've heard about this, the longer follow-up, the better the screening becomes, and the wider the gap you see between the curves. So with about 20 years of follow-up, you can see that you can reduce prostate cancer mortality by about 1/3 with regular PSA testing. There was also a study in the UK that showed that just one PSA is also not too bad. You can reduce prostate cancer by 8%. But if you want to have a greater benefit, we believe that screening needs to be a dynamic process over time. We mentioned the digital rectal examination, and it's definitely a good test, and it's definitely part of a clinical workup for an elevated PSA. So Dr. Moses and colleagues do this all the time in their clinics. But as a screening test, it actually is not very good. It has a very low value in terms of positive predictive value because it's very difficult to find something just with the finger. So the PSA test and the levels of PSA in blood is a much more sensitive test. We also now have ways to use genetics as part of our risk stratification. So definitely strong family history, genetic predispositions with these genes, and then also what's called polygenic risk scores. And there are some of those out there on the market, and they can also help improve the risk of prediction of prostate cancer. We also mentioned race, so African ancestry, definitely increased risk of both being diagnosed with prostate cancer in early onset and dying from the disease. So therefore, in this guideline that we developed with the PCF, then baseline screening is recommended between 40 and 45, and also strongly considering annual screening for Black men. There are also other tools that we can use in our toolbox, and what simple and cheap is risk calculators. They're available online, and some doctors use them in their offices to determine who needs a biopsy. So here you can input things like race and age and PSA and GRE and biopsy and family history, and that can then give the doctor a risk of having high-grade disease on prostate biopsy, or determining if the risk is so low that you can wait with a biopsy. So this is a very simple tool that's very useful in the clinic. What else can we do? Well, there are many ways to roam, and scientists and doctors are trying to figure out which one is the best, and maybe the answer is none of them, but multiple ways. Historically, we used to only do the PSA and GRE and then go to ultrasound-guided biopsy. But now there's so much more. We have MRI that really has been a game changer. We see definitely more and more men coming in with a prostate MRI before biopsy. And we can now do better targeted biopsies to what looks suspicious on the MRI. So it's really definitely been a game changer. And then you can combine these things with biomarkers and genetics. So there's multiple ways that we can refine risk and reduce the number of men who need to undergo a biopsy, because we don't want to put needles in prostates because there's a risk of infection and bleeding, and it's uncomfortable. So definitely using smarter screening can keep the benefits but reduce the harms. And of course, we don't want to overdiagnose the slow-growing prostate cancers, but we only want to find the ones that we really need to find early. And so here's just an overview of some of these ongoing studies that are now happening all over the world. And you can see that the common themes here is PSA combined with MRI in one way or the other, whether it's biparametric or multiparametric, where you also use the contrast to have even better images, and then combining with different biomarkers. And really what MRI has added to screening is that it increases the odds of finding significant disease if the MRI is positive. And we keep the detection of significant disease. So we do find the ones we don't want to, what we want, and we don't find the ones we don't want to. So we reduce overdiagnosis and also unnecessary biopsy. So we kind of win in every level in terms of maximizing benefits and minimizing harm by adding MRI before biopsy. But it's important to remember that a chain is only as strong as its weakest link. So for this concept of pre-biopsy MRI to work, we really need to have a chain of events that works together. So access to high quality MRI studies and standardized protocol and optimized readings and well-trained radiologists, and also high quality targeted biopsy and experienced urologists who do the biopsies. In terms of biomarkers, it used to be only the PSA, but now there's really been an explosion on the market. And here's just an overview, and we could talk about this for another hour. And there's multiple tests out there that are available. And what they do is they increase the specificity of the PSA test, so they can really make screening better, and again, reduce the need for biopsy. And here's another example from the Göteborg 2 trial, which was the study after Göteborg 1, where we combined PSA with MRI and only put needles in what we saw on the MRI, so targeted biopsy. And that shows that keeps the benefits and reduces the harm. So we could find the significant cancers, but avoid finding the low-risk cancers. So we avoided overdiagnosis with this approach. And here's another example from a study from Stockholm in Sweden. And there's a test called the Stockholm 3 test, which combines clinical data, proteins, and genetics. So it's called the multiplex test. And if you use that before MRI, you can further improve the specificity. So you reduce biopsies, keeps the detection of high-grade disease, and reduces overdiagnosis. And there's also a study in Finland that looks at another biomarker called the 4K score. And the 4K stands for 4 kallikreins, and that in combination with MRI has the same effect. So less demand for MRI, and then reduces the risk of biopsy. So in summary, what we do with smart screening or modern risk stratified screening is that it reduces the number of men who need further clinical evaluation and reduces the number of men who need to get into an MRI. Unnecessary biopsies is reduced, which is a huge win. We keep the detection of high-grade disease and reduces overdiagnosis, which has been the major harm with screening in the past. And we still have a safety net with rescreening, so men can come back for further screening. So you don't have to worry that you've missed something because, you know, we have regular intervals and regular screening. And as my last point, I always want to mention active surveillance, and that is now the preferred care option for men with low-risk localized prostate cancer. And that is an important way to minimize the harms of treatment. So screening always needs to be coupled with active surveillance if we do detect low-risk disease. So with that, I thank you.
Thank you, Dr. Carlsson, for that presentation. I look forward to our panel discussion, and I know that there are folks who've already started putting in questions for the Q&A session as well. So both you and Dr. Moses have sparked some great interest in the topic today. But before we get started with our panel discussion, I'd like to ask one final polling question to gather some information about what is happening in practices across the country or through the participants. And so the poll is before you, and that is, do you talk to people about prostate cancer screening as a routine practice in your practice? And the answers are yes, no, or I don't work with people eligible for prostate cancer screening. So we'll take a good 30 to 40 seconds for folks to complete the poll, and we'll go from there. And I don't want to be disrespectful to the tone of our conversation and the sobriety of the topic, but just to lighten it up a little bit, I'll add a little Jeopardy. Bum, 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 bum. Ooh, high note. Ba-dum, 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 bum, 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 do 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 do. All right, well, here are the results. So we have some who talk about prostate screening within their practice, a smaller percent, very small percentage that don't, and then a significant, all right, don't work with people eligible for prostate screening. That's an interesting percentage point. So looking forward to see how that moves in as we get to the conversation. So can we just, I'll start with Dr. Moses for the panel discussion, and then I'll take a question for you, Dr. Carlsson. Can you talk a little bit more about the decrease in prostate cancer screening rates in Black men versus white men and the increase of later stage disease and kind of what might be happening in that space?
Yes. So as I said before, Black men are less likely to receive prostate cancer screening in general, and that's been consistent over several decades. And some research I've done and others show that Black men, even when diagnosed, not only are presenting with higher grade, higher risk disease, but are actually less likely to receive treatment for prostate cancer after diagnosis. And it goes in opposite direction. With escalating risk of disease, the odds of receiving treatment actually go down. And so it's a sort of a reverse negative trend. Black men, I'll kind of fold in another question, but Black men in general are diagnosed with higher risk disease, higher grade disease, and that increased risk is likely multifactorial. If you think about cancer in general, it's an inflammatory disease. There are studies that suggest that environment can play a role. Genetics play a role. But in general, if you look at the rate of prostate cancer of young men, it actually is not that much different. You look at autopsy studies in their 30s and 40s, there may be a little bit earlier initiation of disease, and that may be why it presents at later stage among younger Black men. But there's likely so many reasons for it, but even Black men in the US compared to Western African men have much higher risk compared to Caribbean men. The only Black men who approximate the US are Brazilians who have a very similar history of transatlantic slave trade and subsequent segregation. And so those are likely the reasons for the differences we see in screening, treatment, and overall survival.
Thank you. And Dr. Carlsson, I just wanted to bring you in a little bit, having sat on the guidelines for the Prostate Cancer Foundation for Black men and African American men. Can you add a little bit, or would you be willing, share a little bit to that particular question in terms of, what went into those recommendations and adding to the guidelines?
Yeah, definitely. And it all stemmed from what you heard from Dr. Moses, that Black men are, highest risk for being diagnosed with and dying from prostate cancer in the US. So given that disparity, we, wanted to examine what is the data out there in the literature and what's the evidence for screening specifically for Black men, have a guideline for Black men in the US, because we felt that was really, an unmet large need that we wanted to fulfill. So we assembled a panel on behalf of the Prostate Cancer Foundation, led by Dr. Garraway and Dr. O, and we met regularly and we reviewed all that literature and really, confirmed that Black men in the US can benefit from a risk-adapted screening strategy, starting these discussions, shared decision-making at age 40, and then considering having a baseline PSA test between 40 and 45, and also considering more frequent screening, so every year. So it's more close monitoring of Black men.
So Dr. Carlsson, you mentioned as a part of your presentation that the DRE should be included as a part of a clinical workup after an elevated PSA, excuse me. Are there other times or clinical situations where it should be included as a part of a regular screening? And I don't want to make any assumptions, but any insight into the DRE as a possible barrier to some men getting screened?
Definitely, it definitely is. So that's why it's, shared decision making again. And several of the guidelines that we serve on, Dr. Moses is on the chair of the NCCN guidelines, and myself as well. And I also served on the American Urological Association guideline. We do still keep the digital rectal examination as optional, so it can definitely be included as part of a screening, in a GP practice, for example, together with the PSA. But it doesn't have to be done. But some might prefer to do it, and like I said, otherwise don't want to do it at all. But the strongest utility of rectal exam is when the PSA is elevated. That's my view. I don't know, Dr. Moses, if you want to add something.
Yeah, I agree. In men, especially a PSA of less than 2, you're very unlikely to feel any sort of gross abnormalities, but it gives us information. So as a urologist, we're not necessarily on the screening front. So actually, by the time they see us, they already have an elevated PSA, they're showing up for biopsy or whatever. So I'll do it to get a general sense of the size of the prostate, any irregularities, if there are nodules. And then if they're going to go for surgery, I can even get some anatomical information on my approach for surgery. So it still gives us quite a bit of information.
Dr. Moses, there's talk that the US PSTF guidelines for early detection are under review. So do you have any insight in terms of what we might expect to see in the future?
So as
the magic 8 ball, that's
yeah, well, so as the chair of NCCN, I probably should refrain from making any sort of prognostication. I'll tell you PSA screening is a political issue on certain level. And it's certainly, a public health issue. And so as more data has come out, and really Dr. Carlsson and her team are behind a lot of that, there needed to be revisions. There are plenty of patient advocacy groups who have gone on Capitol Hill and lobbied for an update. And really the move from a C to a B grade, then, insurance would cover it universally. It would be easier for states to do no-cost PSA testing. It would allow Medicaid to allow for better coverage for younger men for treatment. So that's where I think it's headed, and really just getting it up to that B grade, for more universal coverage.
Thank you. I did not want to get you in any trouble, but I appreciate the response. Dr. Carlsson, can you talk a little bit more about risk calculators and their role in the primary care or / community setting?
That's a good question. In my sense, they're most often used once they come to Dr. Moses or a urologist's office. And to determine, the question is really, should I have a biopsy? So usually that's given into the hands of urologists. I'm not familiar with any risk calculators in the primary care practice. I don't know, Dr. Moses, if you do. Usually they more, have a man's age and the PSA test and maybe rectal exam. That's kind of the tools that primary care doctors use. And then urologists have more in their toolbox. Is that correct?
Yeah, I think so. Our primary care, as I mentioned, they have a lot of things to do. So they're basically using the basics. I've never seen a primary care physician use like, PCPT calculator or any of the adjunctive tests. So that's typically done once they reach our clinic.
And so I guess for either of you to respond, for the medically underserved individuals that can be most at risk, right? I don't want to be pejorative or make too many assumptions, but if we're talking about, particularly if we're thinking about African-American men and their access to care and where they access care, the concern may be about the access to high quality MRIs or other tests and scans. And so any thoughts or reflections, for those who may be in a primary care setting, what might be done to address that, or your thoughts and reflections on moving forward, if you will?
Yeah, I think so. In a resource challenged environment, certainly you can use your basics. And as Dr. Carlsson mentioned, the risk adapted approach is very nice for kind of sifting out who needs, aggressive screening, on a semi-annual or annual basis, and those who could be watched every other year. For those who need next level treatment, MRI, biopsy, adjunctive tests, a lot of that requires a little bit of creativity from the physician. You either have to discuss with the insurance company why you're getting that test. And especially for Black men, you basically have to say, hey, this man is at higher risk because he is African-American ethnicity, positive family history. Use those type of things to justify getting the test. MRI is on the verge of becoming, I think, standard of care. And again, if that B grade happens, then hospitals will be better able to get an MRI done for patients with either elevated PSA or just before a biopsy. So I think that's the hope that we would lead to that point. A lot of men still don't have those resources, and we're just relying on PSA and biopsy. And if that's all you have, then that's all you use. And that's what we used for, several decades before MRI and PSMA and some other imaging came out. So use what you have, get to a specialist, and use a lot of the literature and information that we have to help separate out those at higher risk versus not.
Any other thoughts, Dr. Carlsson, on that?
No, I would agree with that.
And it seems, you referenced, this, Dr. Moses, in your presentation about care teams or how you work with a primary care practice at Vanderbilt. Any best practices that you can suss out and share? I've seen in the chat that there are some folks who do community outreach directly. And so there may be some tips or pointers from either, for both of you, that might be helpful for, outside of a urologist or an oncologist. How might I join in this conversation to help raise education and support screenings?
Yeah, I think it's a really promising thing, and it actually relieves the burden from our primary care physicians. And so we've given them a risk adapted, age adapted sort of protocol or algorithm. And so we say we look at race, family history, age, any other risk factors like a high number of women in the family with breast and ovarian cancer, which does, if they have the BRCA gene that does elevate risk. And so we say if their PSA is beyond this number for their age, their ethnicity, then they can get a direct referral in for a conversation with urology. And we can take those next steps, those next adjunctive tests, the MRI, the exam, things like that. And we can even have that sort of shared decision making. It is a little bit beyond just because they've already gotten that blood test, but we can at least go over, some of the risks and benefits of what we would do next. The risk of urinary infection or sepsis after a biopsy, the risk of cancer progression if diagnosed, depending on their risk level. And there are several centers who've done that. And our primary care practitioners love it because it reduces their burden. They can say, okay, you're a Black man, 45, and your PSA is 2.3, which is, 2 standard deviations beyond that median level. So we'll send you to a urologist and have that specific discussion. But it also saves men, some guy, 85-year-old guy randomly gets a PSA added on for some reason. His PSA comes back at 6. And in our world, as long as they don't have symptoms, a PSA of 6 in an 80-year-old is probably not a fatal problem. And so again, we can kind of reassure that man and say, hey, think you're in good shape. You probably don't need a PSA again for the rest of your life. You're good to go. And that reduces the overdiagnosis in, the elderly or the sick or low risk, but then it also prevents the underdiagnosis or undertreatment of men at higher risk of disease.
Right. Dr. Carlsson or Dr. Moses, this may be one of those things too where getting folks in trouble, and that's not the intent of the question, but there's, with all of the different guidelines and the potential for confusion about which ones to follow and where the emphasis may lie, whereas USPSTF or the AUA, any thoughts or perspectives on, how we can creating more consistency and harmony in screening guidelines amongst the various groups who use them, to help encourage that shared decision making or informed conversation with the primary care provider who may say it's crazy. There's guidelines that are all over the place.
Yeah, I think Thank you, Dr. Moses. I think you laid it out very elegantly in your talk when you said we need to harmonize the guidelines. Guidelines should give guidance, but now they're all over the place and the doctors are confused and patients are confused. So I think we need to come together, and maybe that would be starting with some sort of consensus meeting where all the stakeholders come together, including patient advocates and health policy decision makers, and from these different guideline groups. The US is a big country, so it's hard to have a national program, perhaps, as can be maybe done in a small country like Sweden. But it's bothersome that the guidelines are so different, I think. And that might be depending on how the groups review the evidence and how the processes are, and what guidelines primary care physicians follow versus urologists follow, and so people have different views on that. So I think even that we need to come together on what's the best methodology to develop a guideline. I don't know, Dr. Moses, if you have more insights.
Yeah. I agree with you. And I'm not being facetious or joking, but it may take an act of Congress to make that happen. Like, it literally may take a federal mandate that all the chairs of the different panels and the stakeholders in different organizations come together, hash it out. It'll probably take, it wouldn't be done in a day. It may take a week or a month, but everybody comes in with the literature, hashes it out, and then come together. So yeah, short of an act of Congress, a national health policy, or a true willingness among the stakeholders to get it done, it needs to be done, but it will definitely take a lot of swallowing of pride and a bit of a push.
It's just interesting coming in from the primary care space of like how you got, and I won't say divergent, but how do you get the differences in the guidelines in the first place? And I wonder who interprets the data in what particular way that says, well, this is what we are going to promote and support. So I guess that's another reason to pay attention to, policy and engage policy folks. So to make it happen.
to that point, Mr. Bragg, I think, Dr. Moses mentioned this in his talk about active surveillance.
Yes.
Back in the days when the USPSTF recommended against and gave it a D recommendation stop, there was some degree of overtreatment, and that's troublesome because the prostate is in a location in the body where it's close to important structures, so you can get urinary leakage and erectile dysfunction and bowel dysfunction. So it's not a harmless treatment, but with active surveillance and that becoming more and more embraced and more evidence about how safe it is to closely monitor men with low risk disease, then that I think can be a game changer. And really, if USPSTF goes from a C to a B, then that would be a major sea change. But that requires that they the harms is reduced so much that it becomes even with the benefits. I think before then they their view was that it wasn't. But then the pendulum kind of swung in the other direction, and Dr. Moses showed that with the rate of metastatic disease, because most primary care doctors follow the USPSTF. So saying it's an abandoned PSA, it's like, okay, great, we can allow, just ignore the complexities and we don't have to do screening anymore. And you could see in those curves that Dr. Moses showed that, the mortality from prostate cancer used to go down and then it leveled off in the wake of that recommendation. So that trend needs to be reversed. And I think that's also what prompted the PCF guideline that we worked on, that, the burden on that disproportionately fell on Black men. So the pendulum is swinging. So now can we get it back to the middle and maximize the benefits and minimize the harms? So I think that's where, guidelines need to come together.
I appreciate that. We'll get into some of the Q&A, and I'd like to share that from Zero, prostate cancer. We do have some materials that might help facilitate that conversation at the primary care space, or any space, even if it's within someone's home, about why get a PSA test and, some of the prostate cancer by the number handouts. And so that'll be uploaded into the Learning Center. So attendees that are participating here right now can download that information. We have a lot of incredible material that speaks to some of the different constituencies within the prostate cancer community, African-American men, or folks who are identified with the LGBTQIA community as well, to help provide education and engagement. So when they are in front of the provider, they can ask some, the questions that are pertinent to them and their health and well-being and wellness. So with that, we'll transition over to what we have in the queue. And some things we may have touched on. So, I Doctors Carlsson and Moses, apologies if it's something like, Brian, I said that 15 minutes ago. I just want to make sure that we are able to make people feel heard, that put some information into the Q&A. So, and these will be
Brian, not to interrupt, but some of them I've actually typed in an answer.
Okay.
Some of the questions too, they're like kind of a quick thing. So there's some that already says done.
Got it. Exactly right. Okay. So, did we get to the first here? How effective is prostate biopsy in diagnosing prostate cancer? I want to make sure I'm reading things correctly.
Yeah. So, if you want to start a fight at a urology meeting, talk about the utility of biopsy. The standard biopsy that we do, even though we call it a template, is really just kind of a random biopsy. We go to specific areas and we try to target areas that we know that prostate cancer tends to hide within the prostate. But it's truly just like looking for a worm in an apple with a needle. And so what Dr. Carlsson mentioned is the utilization of MRI to see if there are any specific lesions. And there are modalities where we can superimpose live ultrasound views with the MRI images. And so if there's a specific area that looks concerning, we can actually target it very specifically. And even so accurate that if they come back for another biopsy down the road, we can overlay the previous map and hit that same area and then those around it. So it is mostly effective. A lot of times if men have higher risk features like a PSA, over 15 or 20, and the biopsy comes back negative, but their numbers are concerning, we can always go back and do a second biopsy and try to hit some different areas.
Okay, we touched a little bit on this when it comes to care teams, but at the Tribe Primary Care Clinic, we use a team-based approach with a dedicated patient navigator to help with cancer screening reminders and scheduling. Can you share from your experience as a urologist who can be helpful team members in our efforts on cancer screening and prevention? So that's specific to you, Dr. Moses, but in your research and in your practice, Dr. Carlsson, you may have some thoughts on that too, for what's happening in Sweden, if there's a different makeup or how those are constituted there.
Yeah, our partnership with primary care, it really is about knowing who your partners are. So we specifically went to the primary care physicians and advanced practitioners and gave basically kind of a talk like what I did, and then also talk about the algorithm for getting men in with elevated PSAs. From our standpoint, we have a advanced practitioner nurse residency, and so they can or urology fellowship. So they work with us very closely in our clinic, and we've used them for community talks, for partnering with primary care practitioners and getting out in the community. And so utilize those resources using our advanced practice partners. We've been able to get that information out. And then the other way is through advocacy groups. So you and I are part of Zero and Prostate Cancer Foundation. So those are the ways to improve those conversations.
Any difference in care team makeup abroad, Dr. Carlsson, that might impact the answer in terms of who best to include in a care team conversation?
Yeah, there's a lot of opportunistic PSA testing in Sweden, for example. So, a man can go to his primary care doctor or, as part of a health checkup and get a PSA test. So that's very frequent. And the government has been similar to the USPSTF, very much against PSA testing on a national scale. So we don't have a program like for mammography or cervical cancer screening, for example. But there's now a shift, and there is now a climate for PSA testing, and that might change. So currently we have organized prostate testing programs, and I'm part of those as part of my affiliation with Lund University in the southern Sweden. So we are now in a more structured way inviting men. So it's, sending out electronic invitations to men to go get a PSA test. And then the workup for men with elevated PSA and then getting an MRI and seeing a urologist is more structured. And so we're now learning from that initiative to see, how many men show up and, did they adhere to the program and what were the outcomes? And there are similar initiatives throughout Europe through what's called the Praise You Consortium, and it's led by the European Union. And they have then allocated money for these pilot programs. So it's kind of coming from, the leaders and from health policy decision makers and the government in the different countries to then, allocate money and resources to test these programs in a more structured way. So it's interesting to see what we can learn from those initiatives and whether that can then be rolled out into more, national screening programs.
Excellent. At what age and how often men in testosterone therapy need to be screened for PSA, especially if they have a history of BPH and chronic prostatitis?
Yeah, that's a good question. So anybody considering testosterone therapy, they need to get a PSA before starting, just to get a baseline. And if it is what we consider abnormal, needs to get a biopsy first. And then after starting testosterone therapy, you should get a PSA within about 4 to 6 weeks after starting to make sure there isn't a jump. Testosterone replacement doesn't necessarily predispose you or cause cancer, but if there is a underlying, maybe a low-grade cancer that's smoldering, testosterone can aggravate it because that is what the prostate cancer cells use as their fuel for growth. And so men on testosterone should definitely get their annual PSAs and have a bit of a lower threshold for getting a biopsy if they see small increases.
You agree, Dr. Carlsson?
Yes.
All good. Okay. So the next question up is, with delays in screening, what is the impact, both in terms of staging and cost of a later diagnosis? Dr. Carlsson, you take that.
Yeah, I think that's a really interesting question. And, the whole premise of screening, in my view, is to, early detection and really introducing that stage shift where we detect cancers at a much earlier stage and we can prevent the development of metastatic disease and dying from prostate cancer. So we looked at this in the European trial and we did what's called a cost effectiveness evaluation, or a sort of economic evaluation of everything, if you will get screened and if you don't, and what happens, all the downstream events, what's the cost of the testing and the biopsy, and all the downstream sort of health states, and what happens if you're diagnosed and you get treated, and if you're living with the long-term side effects of treatment, and if you live with metastatic disease, or you're in palliative care, all possible costs with those two scenarios. And it shows that screening can be cost effective, but the major harms and is really the side effects from treatment and living for many, many years with those. That's really what's costly, both in terms of quality of life for the individual, but also in terms of money. And what's also really costly is then the late stage disease, metastatic and palliative care. So I think that's where screening can have a huge big cost saving, later on, but it can be a cost initially with expensive testing and workup, but you kind of save that later on. I don't know if that answers your question, Sandra.
Well, let's see if she has a follow-up in this session. So far, we're good. There was a question in the webinar chat that has any research been done to correlate the connection between elevated PSA and prostate cancer and men carrying their cell phones in their pants pockets, like EMF from the phone?
Yeah, I just typed a response. I don't know of any data that shows that. I think it was last week, there was a big study done in the US on the risk of brain cancer. So there has been maybe a slight increase in brain cancer over the last several decades, but the difference in cell phone usage versus not and brain cancer was not, there was no association. The problem is, it's just like PSA screening. It's like everybody's got a cell phone now, and even if you don't, you might be within 10 feet of someone using it. So it's kind of hard to say. All of my 80-year-old patients have cell phones now, so I think it's pretty pervasive. But at least on a population level, there's no data that connects the two.
And mad props to your 80-year-old patients. So that gets rid of that trope about seniors and their utilization of modern technology. The next question in the chat: if an overall healthy patient in their 60s gets a biopsy and the results are over 6, what are the typical next steps to be taken?
Yeah, if the Gleason number is over 6 or the PSA?
It is not clear, so I'm not sure what.
Is that's in the Q&A part?
Yes.
And patient gets biopsy results that are over 0.6. I'm assuming they mean if the Gleason number is over 6. So just for the audience, Gleason is what the pathologist uses as a report for the aggressiveness of the cells under the microscope. And so grade 6, or what we call Gleason grade 1, is low risk. And as Dr. Carlsson mentioned, we typically will approach that with active surveillance. Whereas if the number is above 6 and can go 7, 8, 9, or 10, for those men, we typically will recommend definitive treatment. And so it's either some version of surgery or some version of radiation. Surgery can be done open or minimally invasive, and it typically involves removing the prostate plus or minus the lymph nodes in the area. And radiation can be external radiation. There's different versions of that. There are radiation seeds that can be implanted in the prostate. And then there are other sort of what we consider less invasive or non-invasive, like high frequency ultrasound or cryotherapy that could be used. So there are lots of options. I would say go to either the Prevent Cancer website or to Zero, since you have two representatives here, or even the American Cancer Society. They'll have a good description of the options that are available. What we do when people are diagnosed is we do risk stratify. And for each risk category, we have what treatments we think are the best, depending on their level of disease and their overall health status.
Anything to add to that, Dr.? Oh, Stephanie.
No, great.
Thank
Yeah.
you. So I guess we answered that question appropriately. So for the both of you, and there may be some synergy or alignment, in the response or the answers, what does, in thinking about, where we are right now when it comes to early detection and screening, and, the research that you both have been involved in, and the conversations regarding guidance and guidelines, and understanding that we are not at the point of harmony yet, and there's no one acting as the strong arm to pull those things together. What might success look like? Have you thought about what the milestones would be, generally, or maybe, and then specifically when it comes to some, high risk populations? What does success look like? Or what might it look like? So nothing to be so definitive or prescriptive, but what might be some things where, okay, well, this is where we know that we're actually making the kind of impacts that are going to be important, for the long term.
Well,
Yeah,
Sigrid, you're our population level scientist here.
yeah, well, I think if we can come together, as we talked about with harmonizing the guidelines, if we can just be a more cohesive group in the, medical community, I think that would be a huge win, because, currently there's so much different guidelines, and there's, misinformation out there. It's confusing for men at risk. So I think that would be the first step. And then, in my view, more personalized, targeted screening that maximizes the benefits and minimizes the harm. I think that is really the future. And we can, use that in a more cost-effective way. There's also modern tools such as, AI that we can use to help interpret MRI readings. And there's more and more automation we can use, and making it more kind of equitable in a way, because it's, it could depend on the radiologist looking at the images. So I think making everything more efficient, if you will. Now it's kind of all over the place, and can we come together, and can we have a solid sound approach? It's abandon the one size fits all, but then using it more personalized and targeted. That would be my vision. And Dr. Moses, what's yours?
Agree, completely agree. Everybody who needs to be diagnosed is. Everybody does not need to be diagnosed is not. We close the screening and treatment gap among Black men and those at higher risk. And really the appropriate aggressiveness of treatment based on risk level. So those at low risk, no treatment at all, versus those at high risk, multimodal, multidisciplinary management of high-risk disease. We tell men with metastatic prostate cancer that there's no cure, there's management. And ideally, if we can find the right balance of aggressive treatment with maintaining quality of life, that would be, I think, success.
That's helpful. Any specific points that either of you have had, in practice for those men who are under the age of 50, who, and you've touched about this in terms of high risk, and what does high risk mean? Any particular points of persuasion that have led to successful rates of screening, for those men that are under the age of 50?
For younger men, you have to make it personal. And I have plenty of stories of men diagnosed in their 30s and 40s with significant disease. Many of these men have family members or know somebody that's had prostate cancer. So personalizing that story, I think, sometimes helps crystallize it. My chair, when I was a resident, he said all men are immortal until they turn 50. And really what he was saying is that men all of a sudden realize, maybe I should go to the doctor every year like my wife does, or maybe I should take care of my health. I'm not going to live forever. And so for younger men, kind of having that conversation saying, hey, look, these are the kind of things that will be important to you, and let's educate you now. So when you do turn 45, when you do turn 50, you're getting that PSA done, you're getting that colonoscopy, you're, increasing your exercise, you're changing your diet. You know, this is the area where women have left us in the dust. When breast cancer was destigmatized in the 70s and 80s, screening rates went through the roof, funding went through the roof. Breast cancer funding way outstrips prostate. And so we could learn something from the women about how to discuss these personal, intimate issues, but also, you know, understanding what your risk level is and why it's important to get screened and treated.
Any thoughts and reflection? I thank you for bringing up stigma, because, you know, that is a challenge, you know what I mean, when it comes to this conversation, not specifically in the clinical setting, to which you all can speak. You know, there's sometimes a persuasion that can happen when you're talking to a provider that's different from a community-based conversation and when you're talking to your peers. And so, you know, you mentioned that the breast cancer became destigmatized, and I just want to get both of your all's thoughts and about the conversation about prostate cancer and then getting screened for prostate cancer that may be embedded in the community and ways that we might overcome this. Because for some, you know, once you get some in front of a provider or a clinician and so forth, they're all right, you may get the outcome that you'd like. Yes, I will get screened. I've been, you know, educated on risk factors and why I'm someone who's below the general age, and, you know, I'm an African-American man or I'm a veteran and so forth. Therefore, these things are in play. That conversation is different from what might happen at the barbershop, or how men who have a diagnosis may speak about it to their friends in their friendship circles. And so any thoughts and reflections on what, I mean, your perspective on that and ways that we can sort of together address those things and decrease the stigma?
Yeah, I think you bring up such an important point. I mean, I've heard of men who've been diagnosed with prostate cancer and, you know, they find out then that, oh, their brother or their dad had it without them even talking about it. So we need to really remove the stigma and the myths about screening. And as you mentioned before, I think that the blood test is a huge help there, that it's, you know, a simple test and it's non-invasive and in a way, and it's just, you know, simple test. And then raising awareness. So with initiatives, you know, like this, with the Prevent Cancer Foundation and with Zero and other organizations about, you know, screening and what it entails. Dr. Moses.
Yeah, I agree with that completely. The destigmatization starts with being honest with men and say, hey, yeah, prostate cancer can affect your erections. It can affect your sense of manliness. It can affect your relations. It can affect your urinary function. How can we prevent it from having such an impact that it decreases your quality of life? And that's where you bring in the screening and say, hey, if we can diagnose early and either not treat or provide the most quality of life preserving treatment, great. Men with symptoms of prostate cancer, is too late. You know, our ability to prevent those complications goes away. So if those are things that you prioritize, let's address this now. Let's nip it in the bud. Let's be proactive. And then the other thing, I've had men who will come in with their significant others or their children, whatever, and they say, you're not sticking a finger in my butt. You're not doing this. You're not doing that. And then I turn to the wife or the husband or the girlfriend or the daughter, and I say, do you agree with that? And then I ask me, I say, what do you live for? Like, what is your motivation in life? And almost always it's, you know, it's family, it's their career, it's those things. And then I say, okay, well, let's maximize your time with family. Let's maximize your career productivity by taking care of this issue now so that it's not a problem for you 5 years, 10 years, 15 years down the road. So if you can make that story personal, if you can make it, you know, help them prioritize, I think that's how you destigmatize and get through the message.
I appreciate that. Since coming to Zero and being able to participate in some of our virtual support groups, particularly the African American prostate cancer support group, there have been conversations where folks have been painful. They talk of the loneliness of a diagnosis and the challenge of sharing. And so the guidance that we need will be helpful to get out of this. And it gets me back to the care team conversation about who best to have a conversation regarding screening. I think that's also an appropriate, reflection on who best post-screening to have a conversation to be to added to the care team. And I know in some primary care practices, social workers are part of, you're diagnosed with diabetes or you have a diagnosis with any chronic condition, there's a referral to a behavioral health consultant. And so there are opportunities there to help folks to process what did I just learn and how can I, get the resources and support that I need to move forward. And that I know that we have some great resources at Zero, and other folks across the spectrum of provider practices also have some additional supports as well. So I've seen in the chat that there are lots of great ideas regarding navigation, community education. I do think it is a coming together. And until the agencies, hit symmetry. What is, I forget the simulation. I don't want to get caught up with AI and like human psychology, but until we come together there, I think there's a lot of things that we can do in practice and in community settings to help further this conversation along and get to see what we would love to see. So any other final thoughts and reflections from Dr. Carlsson or Dr. Moses? I want to thank you for your presentations, and I want to thank all those that are participating for the incredible questions and the engagement in the chat. Fantastic. It takes this virtual world and makes it really real. So I appreciate all of that engagement. Any thoughts, Jody, from your end?
Oh, I thought it was amazing. I thank you so much for moderating, Brian. That was fantastic. I mean, we are so grateful to all of you for your incredible, thoughtful contributions. Dr. Carlsson, Dr. Moses, you're a fantastic panel. Brian, you not only moderated, but you gave us a live rendition of Jeopardy music for the questions. And I couldn't possibly ask for more. And thank you for Zero Prostate Cancer joining us in partnership for this dialogue. So I just want to let everyone know that as a next step, you can visit the e-learning platform for everything that you need. That's your certificates, for continuing education credits, on-demand content. And while you're there, you please do fill out the feedback form. Just forget about the whole beginning portion where I kept myself on mute. We'll just pretend that never happened. But do fill out the feedback form so we can make sure and keep these dialogues great. And that's it. I just want to thank all of you for joining us today and wishing you all a wonderful rest of the week.
Thanks, everyone. Have a great day. Bye-bye.
Thank you very much.
Thank you.